Hello?
Okay, we're going to start the broadcast right now.
The broadcast is now starting. All attendees are in listen-only mode.
Thank you for joining Cepheid's webinar forum. Today's webinar is Decreasing MRSA Transmissions and Surgical Site Infections, a case study. In 2006, the Michael E. DeBakey VA Medical Center in Houston, Texas, implemented an MRSA prevention bundle that included rapid PCR surveillance to decrease MRSA transmission and healthcare-associated infections. The success of this program was detailed in a recent article titled Implementation of a Methicillin-resistant Staph aureus Prevention Bundle Results in Decreased Surgical Site Infections, and it appeared in the American Journal of Surgery. We are pleased this morning to have two of the article's authors, Dr. Samir Awad and Patricia Byers, present the details of the VA Houston's MRSA Prevention Bundle and the positive impact that it has had on reducing MRSA surgical site infections in their patient population. We will start by having Patricia Byers provide an overview of their hospital's MRSA infection control program, and then we will have Dr. Samir Awad present some of the program's very favorable results. We are pleased to have you in attendance today and hope you find this program informative. Before we introduce today's speakers, I would like to review a few guidance items for today's program. To begin with, today's slide presentation will run for approximately 40 minutes and will be followed by a 20-minute Q&A session.
Go to webinar.
Due to the number of attendees, we will only be able to process questions that are submitted via the question function on the webinar program. Please feel free to forward your questions to us at any time during the program. We will do our best to address as many of these as possible within the allotted time frame. Second, if you'd like to receive additional information and/or a copy of today's presentation, please fill out the survey at the end of today's webinar. And finally, a recorded session of this program, as well as a previously broadcasted webinar programs, are available through the Cepheid website at www.cepheid.com/events. You'll also be able to view and register for upcoming webinar sessions on this webpage. Today's program will begin with Patricia Byers. Pat is the first MRSA prevention coordinator at the Michael E. DeBakey Veterans Affairs Medical Center in Houston, Texas. She has been in this position since November of 2007 and is part of the original facility implementation team when the VHA MRSA bundle was implemented in 2006 on one medical unit. Previously, she has been an infection preventionist at the same facility since 1991. She is trained as a clinical and research microbiologist and is certified in infection control. Prevention of healthcare-associated infections is her interest, as she now heads the MDRO prevention team for her facility. Following Patricia will be Dr. Samir Awad. Dr. Awad is an associate professor of surgery and chief of the section of surgical critical care in the Department of Surgery at Baylor College of Medicine. He is also the associate chief of surgery and medical director of the SICU at the Michael E. DeBakey Veterans Affairs Medical Center. Dr. Awad received his medical degree from Thomas Jefferson University, and he completed his GS and surgical critical care training at the University of Michigan. One of his main research interests has been in the area of healthcare-associated surgical infections, and he is well published in this field. So we are pleased to host our distinguished panelists, and I present to you this morning Patricia Byers. Pat?
Good morning. Thank you all for joining us so that you can hear our story, and I hope that in the future we'll be hearing many more stories from your facilities that mirror what we've been able to accomplish. Next slide, please.
Yep.
Well, I give this as an example because, as we all know, MRSA became a problem in the community back in 2003-04. And we had a study done at our facility that showed when we looked at blood culture isolates picked randomly from July 03 to June 04, 65% of the strains were community-acquired MRSA or type 4. We had 35% of the strains healthcare-acquired strains or type 2. And in addition, when we looked at the patients, whether the infection was acquired in the hospital or not, 81% were healthcare acquired due to the community-acquired strain. Next. Next slide, please. There we go. The Veterans Health Administration in 2006, coming from the results that had been seen at the VA Pittsburgh healthcare system, where they had noticed decreases in MRSA transmission within their facility, decided to offer the opportunity to 17 other hospitals to be beta testing facilities. We were one of those. And we then engaged in the VHA MRSA bundle, which is very similar to the Institute for Healthcare Improvement bundle. The first one was leadership engagement. Make sure that your hospital leaders understand why this is important and commit to giving you the resources you need. Staff engagement and co-creation using PD. This is positive deviance. We'll go over that in a minute, and I might say this is the critical element in this whole evidence-based practice bundle. Active surveillance testing, NARI screening on admission, transfer, and discharge. Hand hygiene, we decided on a protocol to sanitize with hand gel going in with alcohol-based and then wash your hands before leaving the room. Contact isolation for all MRSA-positive patients, everyone wearing a cover gown and gloves when crossing a red line, which was placed in every room right at the sink, at the area of the sink, so that anybody going over that line approaching the patient was required to gown and glove. Environmental and medical equipment cleaning between patients. Again, a kind of a change for us. Go ahead. Next slide, please. Well, these are the strategies that we used for success, and we have not achieved complete success, but we're well on the way. Commitment of leadership to promote cultural change. Our main leadership champion was our nurse executive and our associate director, and both were vitally involved in starting us on this journey. Commitment of sufficient fiscal resources, supplies, equipment, and staff. Again, if leadership was very supportive in this regard. BHA, IHI, MRSA bundle. We followed the bundle exactly. Continued practice of culture change to empower frontline staff. Again, this is critical to having sustainable change. And real-time data feedback to staff and leadership. Again, critical to know what's really going on and how the staff can actually be involved in change to prevent infections. Next slide, please. Our MRSA prevention team was rather broad-based and multidisciplinary. We had all of us that were in the infection control department involved as champions. We had some excellent champions in our microbiology laboratory early on. We had an infectious disease physician. We had surgeons. Dr. Awad's been a champion from the very beginning. Staff nurses, nurse managers. Information technology was critical in getting this going with automating of orders and listing of positive patients every day on reports. Medical supply specialists to assure that we had the supplies we needed to do isolation precautions correctly. Environmental services staff, again, involved early on as champions to assure that the room cleaning was the top-notch protocol that we could use. And medical support assistants who ran each nursing unit and were very critical to making this work. Next slide, please. Okay. Again, one important thing to look at if you're wondering, can we afford this, is to look at the cost of treating patients with MRSA infections in your facility. And the question, what is the cost of a life, is critical. Healthcare-acquired infections, HCA, after 48 hours in the unit, that's what we wanted to prevent. So we went back and searched through our data to see how many patients did we have. We did several case studies and compared patients for our leadership so they could understand the costs involved in treating patients who either acquired in the hospital or came to us with a significant MRSA infection. The cost of isolation supplies, the isolation supply cabinets, which we installed outside every room, even simple things like a trash can so that we could hold more gowns or whatever else we were, gloves and so forth that we were using. We standardized the collection swabs and the PCR reagents. We were one of the first VA hospitals to adopt the Cepheid GeneXpert to do our PCR screening of NARI swabs, and then selective media. We accomplished both of these in that we just did that for discharged patients as a cost-saving measure, and that's worked out well for us. New personnel. The VA actually funded an MRSA prevention coordinator at each facility. We additionally added an MRSA program analyst. The Central Supply Department did a cost study to show what it would cost, what time it took to stock all of these cabinets throughout the facility. And they justified 4 additional positions, and they were granted those individuals. So they joined what they call our MRSA attack team, and they supply those supplies to this day to every unit in the hospital. Microbiologists, again, critical. We had to add several people in our microbiology department because of the workload, and housekeepers. We haven't been quite as successful increasing our staff there, but they're vitally involved in our control efforts. Preparation and presentation of a budget, we actually did that as infection preventionists, which was a real eye-opener for me, I know, just to see the costs involved in not only setting up the program, but what costs were involved in treating the infections. We had hospital-wide education of staff in December of 2006. We had a hospital-wide kickoff. We had an expert on positive deviance, Mr. Jerry Sternin, who came to speak to us. Dr. Awad spoke. I spoke. We tried to give employees an understanding of what was involved in this initiative and why we were doing it and why we needed their help. And then we recruited MRSA champions, and that's still to this day an ongoing process as we have turnover in personnel. But critical because this was the train-the-trainer approach. Next slide, please. Facility-wide implementation finally occurred by October of 2007, but we began originally in 1 medical unit in October of 2006, a second one which was an intermediate care unit in February 07, and 3 ICUs by the end of June of 07. Then additionally, the VA decided this should be implemented also in our long-term care units. They're called a community living center. So we implemented it in all 4 community living center units by December of 2008. Next slide, please. The power of positive deviance is just empowering frontline staff who probably know some of the ways to correct process failures in healthcare. We know that they're very complex processes when we provide care to patients. And as it says here, solutions before our very eyes. In every community organization, there are individuals or groups whose uncommon practices and behaviors enable them to find better solutions to problems than their neighbors and colleagues who have access to these same resources. And as we're all noticing, limitation of resources, this is a great method to use what we've got and go to the frontline staff who know how to correct the problem and involve them in developing solutions. Next slide, please. So the positive deviance focus is actually on changing practice rather than knowledge. So, and Mr. Sternin had a great way of putting this. It's easier to act your way into a new way of thinking than to think your way into a new way of acting. And as we've gone through this journey, this works amazingly well, that you change your practice first. We've all done training and training and training to try to change behavior. It is not effective, and this method is. Next slide, please. So we consider the key concepts. Community ownership, that means whatever area you practice in, everyone has a stake in it. Everyone has a chance to suggest changes. Self-discovery means that everyone that works in that practice area, be it a clinic setting, a nursing unit, an invasive procedure area, everyone has a chance to discover the solutions. And the people that do have hands-on with the patient are the experts. The immediacy of action means you immediately put the changes into practice, you try them out on a smaller basis, and then you go forward and spread them as you find that they work. And then ongoing measurement reinforces change, and that's absolutely critical. We have 4 main graphs that are posted on every unit. We follow swabbing rates in and out for the screening. We follow MRSA transmissions and MRSA healthcare-acquired infections that occur on each separate individual unit. And that data is available for not only the staff to see of all disciplines, but patients or family as well. It's in a public area. Next slide, please. This is a graph of what's judged to be business as usual. leadership, powerful and few, make decisions about how the work is done. So there we have the tip of the triangle. Middle managers implement decisions, and frontline workers, experts at the work they do, carry out decisions, rarely engaged in deciding how the work is done. And we flip to the next slide, and we'll see under positive deviance, the triangle has been flipped. Cultural transformation then involves frontline workers, experts at the work they do, decide how to do the work, and decide among themselves, we know how to make this work. There's somebody in that group that knows how to make a process work, and we all listen to each other. Leadership and middle managers then support and filter ideas and remove barriers for implementation of practices for the frontline workers. And that means that you have to have a regular interchange of ideas and information between leadership, middle managers, and frontline workers. Next slide, please. This is one way that you can do the regular interchange, the communication, called a unit briefing, short and sweet, staff-owned and operated. We've had housekeepers do unit briefings. We've had nurses do unit briefings, and others, even unit clerks do unit briefings. All healthcare specialties and vocations are involved, whoever's on the unit at the time you're doing the briefing. Leaders listen and support. We invite our leadership to attend, so we'll put out a schedule, and at their discretion they're able to attend. Staff reviews their performance data, problems discussed and solved, and successes celebrated. Now this should take all of 15 minutes. Sometimes when you're first getting started it takes a little more than that. These are stand-up meetings at the bulletin board at the front of the unit. Next slide, please. Key elements for success. Data collection in real time. I've been in infection control a number of years. This is always a challenge to get data collected and analyzed and back to the staff in real time. That's the challenge. It's still a challenge. We're doing much better than we first started, and it helps if you have good information technology support at your facility to be able to do this. Real-time data feedback of admission and discharge swabbing rates and MRSA transmission and infection rates, and those are those 4 graphs we talked about that are updated monthly. Weekly unit briefings involving administration, infection control, all support and healthcare staff. And then staff involvement in the culture change is now part of their daily practice. And once you begin to see this, it's amazing. Because having been in this business so many years, it's difficult to see this kind of change occur with multidisciplines functioning in, we've got 15 different inpatient units and 4 long-term care units. And each one has approached this a little differently, but the results are the same. We've seen amazing decreases in MRSA healthcare-acquired infections. Next slide, please. So again, our outcome measures are admission swabbing rates. That is, everyone who is admitted to our facility, regardless of their history of MRSA or not, is swabbed, a nary swab on admission. On 2 of our units, we actually do admission wound swabs as well. Exit. In other words, someone leaves the unit, is to transfer or discharge, everyone is swabbed. However, we have made some changes in our business rules such that if someone is positive on admission, by screening swab, they're not required to be tested again. However, they do remain in isolation for the duration of their stay. Number of patients colonized with MRSA on the nursing unit. The definition here is if they have no history of MRSA in the last year, and they're on your unit more than 48 hours before they leave and go to another unit or go home, and you test them on exit and they are positive, they're considered to be colonized on your unit. Number of patients with new MRSA infection on the nursing unit, again, we use the 48-hour rule. CDC uses the 72-hour rule. We still hold with the 48-hour rule, and anybody who does not have an infection incubating at the time of admission or entry to your unit, who then develops an infection on your unit due to MRSA as one of the pathogens, is considered to have developed an MRSA healthcare-acquired infection. And then we do monitor monthly by observation, hand hygiene, and contact isolation compliance. Right now, each unit does it themselves and submits the observation. We're moving into a program. We use what we call secret shoppers or hand-washing spies, if you will, to do that in a more objective manner so that we don't burden the staff on the unit, but still they get feedback as to how good the compliance is with these very important infection prevention measures. Next slide, please. The clinical microbiology laboratory was integral to us doing this initiative. We acquired our first 16-module Cephia GeneXpert in May of '07 and our second in October of '08. We monitor, we look for turnaround time, we look for the correct swabbing technique. I do training with all the clinical staff once a year, timely notification of results, contact isolation for anyone that's positive. And right now we don't have any additional staff so we can do it 24/7. Next slide. Here's the laboratory staff in microbiology. Again, our testing protocol, annual training, and then PCR testing is actually available 12 hours daily. Next slide. Information technology is critical as well. We automate orders. We had automated orders for NARI screening tests on admission, discharge, and transfer, electronic patient admission and discharge list that we were able to obtain so that we could follow our patient movements, automated tracking of swabbing rates, automated notification of nursing staff by what's called our contact isolation list, a clinical alert if a history of MRSA. This is something we're working on. We think it would be most helpful. Case review using Theradoc 24/7 surveillance software. Next slide. And finally, facilities management or environmental management. The folks that keep the hospital clean, absolutely critical to getting this initiative started, assuring that we had a clean environment and that we supplied individuals with all the protective attire that was needed. We had disinfectant wipes in every room. We did look very critically at our patient room cleaning protocol and did revise that. And I think that's the last of my slides.
Thank you, Pat. Good day to everybody. And as you could see from the monumental and heroic efforts of all the people that participated in the MRSA implementation prevention program, you could see what the tools that were needed to make that a success. And the question is as well, how can one person make a difference? Well, what Pat has described to you in what is required for the hospital to undertake a cultural change is significant, and it does carry its own energy and does lead to success. But how have we done? What are some of the markers to look at to see if the program that that has been implemented has been successful? And this is where my interest in looking at surgical site infections, one of the healthcare acquired infections that is very pertinent to my line of work, to determine if indeed a prevention bundle can impact that over the time frame where we implemented it. And also I was very interested to see what happened to healthcare acquired infections at our institution. And finally, we will be showing you data across the VA where institutions that have implemented this bundle and have had the same kind of buy-in from their institutions and their workers and their healthcare providers, and how that has impacted MRSA healthcare acquired infections. So we went ahead and looked at this goal. Next slide, please. As you can see from healthcare acquired infections, surgical site infections are those that are defined as infections that present up to 30 days after a surgical procedure, and check this, up to 1 year if a prosthetic is implanted. And that obviously can carry a significant morbidity and mortality. Surgical site infections are the second most common healthcare associated infection, accounting for about 24%, and are preventable. And this is one of the things that is now CMS and other payers have focused on, such that in the coming years, if you develop a surgical site infection, which is supposed to be a zero-rate infection, that you will not get reimbursed for that. So it's very important and very apropos to try to put in all the necessary pieces of the puzzle that will get your surgical site infections rates down as low as possible. Next slide. If you look at surgical site infections, MRSA surgical site infections have been shown to prolong hospital stay, increase costs, and significantly increase mortality. And this has been reported in the multiple studies, such that the cost of an MRSA surgical site infection can be up to $70,000 compared to a sensitive infection, which carries an infection cost of about $40,000. The increasing incidence of MRSA has led to national mandates to institute measures of prevention, and not only has this been done at the VA, but is now catching on in the private sector with the IHI initiatives, and I'm sure, with what CMS is doing. Next slide, please. In late 2006, our hospital committed to implementation of the MRSA prevention bundle in an attempt at decreasing MRSA transmission, as you heard, with all the wonderful pieces of the puzzle that Pat and the rest of the team had put into place in order to get our culture to change and to be proactive in preventing MRSA infections and transmissions. Next slide. So our objective with the study that we undertook was to examine the impact of the MRSA bundle on surgical site infections, as well as the impact on healthcare-associated infections hospital-wide. Next slide. For this, we implemented the MRSA bundle in September of 2007, and the bundle consisted of the 5 elements: MRSA nasal screening of patients upon admission, transfer and discharge using the Cepheid GeneXpert rapid PCR, contact isolation of positive patients, standardized hand hygiene with gel in and gel out and wash out, cultural transformation campaign with staff and leadership engagement using positive Deviance strategies, and then ongoing monitoring of processes and outcome measures in real time. Next slide. The data was collected over 2 years, and it included admission and discharge MRSA nasal screening. We wanted to look at the prevalence of MRSA in our facility because we did not have a good handle on this with variable rates over the years from prior looking at this number. We wanted to look more importantly at the rates of MRSA transmission. We wanted to specifically look at MRSA infections and other nosocomial infections during this time frame after implementation of the bundle. And then most specifically, we wanted to look at patients who actually underwent a lot of hardware implantation procedures, such as cardiac surgery patients and orthopedic surgery patients, as the first 2 groups to look at surgical site infections and to see if there was an impact. Chi-square analysis was used for all these statistics in this study. Next slide. Here are our results. As you can see here, the 2007 data is shown in red and 2008 shown in green. And as you can see here, the prevalence of MRSA actually remains stable at 18%, as you would predict. Typically, unless something is going to be done at a community or social level, you're not necessarily going to see a decrease in the prevalence over this time frame. When we looked at the MRSA screening on unit admission, we found that we actually started out pretty good at 94%, and that maintained itself at 95%. And then screening on discharge started out a little slower at 82% and was high, up to as high as 86% in 2008. And this number has subsequently actually increased in 2009. So we're doing very well with the screening on unit admission and on unit discharge. Next slide. In looking at the MRSA transmissions between 2007 and 2008, we were really surprised and very pleased to see that there was a significant decrease in the number of MRSA transmissions from 5.8 per 1,000 bed days in 2007 down to 3 per 1,000 bed days in 2008. And that's a very significant, statistically significant result. The next thing we looked at, the next variable, was the MRSA infections. And again, we were able to show a 50% decrease from 2 per 1,000 bed day in MRSA infections to 1 per 1,000 bed day MRSA infections. Again, that was statistically significant. And even though it may have been 1 per 1,000 bed day decrease, that has significant implication in terms of cost. And we're actually conducting an analysis of this to see the amount of money that we would have saved, even considering the cost of implementing the prevention program. Next slide. In looking at actually the surgical site infections, and this was my main area of interest, we were very happy to see a significant decrease of 25% in the orthopedic MRSA surgical site infection and 50% in the cardiothoracic MRSA surgical site infections over that time period. And this ended up being statistically significant, showing that there was a direct impact on the MRSA transmissions and the decrease in surgical site infections. Next slide. So how did we do as a hospital with MRSA hospital-acquired infection rates? This slide here shows the rate of infection per 1,000 bed days of care for all hospital-acquired MRSA infections. And this looks at a time span from October 05 through February 09. And as you could see here, that the program was first implemented in one unit in October 06. That's the white bar, and the black bar shows the hospital-wide implementation. and you can see that there is a significant decrease in the rate of infection per 1,000 bed days from about 3 all the way to less than 1, about 0.8 by February of 2009, showing a significant decrease in the MRSA hospital-acquired infection rate. Next slide. And how did we do with other markers of hospital-wide transmission that rely on paying attention to hand hygiene and to using your facilities management to make sure that there's clean rooms and the cleaning aspects? So we wanted to look at a marker of that, and one of the main markers is the rate of Clostridium difficile infections. And we looked at that rate of infection per 1,000 bed days of care, again over the same time period, with the same arrows showing, again, 1 unit implementation for white and black showing hospital-wide implementation. And again, we were very happy to see a significant decrease in the rate of C. difficile infections, which, again, are a healthcare-acquired infection and are transmitted from person to person, so showing, again, that there was a significant effect hospital-wide from this cultural transformation. Next slide, please. So in discussion, or in summary, healthcare-associated infections such as MRSA are preventable infections that do have a high morbidity and mortality. Measures such as the MRSA prevention program, as well as all the other measures that are now mandated nationally, which include the VAP, or ventilator-associated pneumonia prevention, and catheter-related bloodstream infection prevention bundles, have been developed and are now mandated, but they have been really shown to work by decreasing these preventable infections and saving lives and saving hospital length of stay and overall decrease in cost. Next slide. Our data here specifically demonstrated that with a hospital-wide implementation of a simple measure such as the MRSA prevention bundle, that we were able to show decreased MRSA transmission, decreased overall number of healthcare-associated MRSA infections, and a decrease in the MRSA surgical site infections, which has reimbursement implications written all over it. Next slide, please. But now, that's great that we showed you what we did in our hospital. Does this really translate across a system of hospitals? And we just got this data very recently, and this looks at the hospital, again, acquired infections in non-ICU patients per 1,000 bed days of care, looking again from October of 2007 to November of 2008. And we wanted to look at the number of infections per 1,000 bed days over that time frame. And as you can see here, there was a significant decrease of 29% in terms of the hospital-acquired infections per 1,000 bed days of care rate just over this time frame, showing, again, a significant decrease when the same tools are implemented in multiple hospitals and you're able to monitor and measure and report, and shows a significant decrease. And most importantly, next slide, is what happens in the ICU, because in the ICU, those are the patients that cost the hospital the most in terms of anybody getting a nosocomial or healthcare-acquired infection. And here, if you look at the MRSA hospital-acquired infections in the ICU from October 07 to March 09, this was outstanding, again, across all the hospitals in the VA that are participating in the MRSA prevention bundle. And what you can see here is a decrease from a rate of 1.8 infections per 1,000 bed days of care down to 0.742, or a 59% decrease, which was highly statistically significant. Again, showing the impact of using this kind of evidence-based practices to affect a significant decrease in the number of infections system-wide. Next slide. So with that, and to sum up both of the presentations, it's really important now to think of trying to identify for the surgical site infection patients ways of identifying these patients earlier. And what we are implementing right now through our partnership and hopefully through a grant from Cepheid is that we'll be looking at preoperatively screening the patients who are going to be undergoing hardware implantation ahead of time, and then trying to provide a therapy for these patients and a strategy so that we can significantly decrease surgical site infections and hopefully eliminate them once and for all. And with that, I think we will wrap up, and we'll be happy to answer any questions, and I'm going to turn it over to Brian.
Great. Thank you very much, Dr. Awad and Patricia. I'd like to thank both of our speakers for an excellent and insightful presentation, and I also want to thank all of our participants for your attendance at today's session. As Dr. Awad mentioned, we would now like to open up this forum to your questions. So for those of you participating either on the GoToWebinar or via WebEx, you can go ahead and submit your questions via the question function on the webinar program. And we will take a moment here to consolidate our questions. The first question we have, and like I said, I'll open this up to both Dr. Awad and Ms. Byers, depending on who has it. It's from Jerry Chris, who asks, can you quantitate the cost impact of this program?
Okay, I'll take that. We actually have a graduate student working on a master's thesis. He's actually a physician who's now in residency. He's done a lot of work on this as far as estimating the cost-benefit of doing the prevention program, and he decided to target just one medical unit and looked at healthcare-acquired MRSA infections and the cost of the supplies. We know that the cost of implementing the program, we know what that was, and we know what the cost is for treating selected infections in our hospital. We're trying to do the cost analysis of more infections other than what the student is doing, and we hope to be able to publish that soon so that we can show the benefit. But I can tell you that just looking at, we did a patient with a diabetic foot infection. We compared the cost of his care to the cost of a patient with the same diagnosis with approximately the same number of surgical procedures. One cost in the area of $60,000 for his total treatment in the hospital, and the other one who acquired MRSA at several different sites, all hospital-acquired infections, as well as other sequelae such as respiratory failure and renal failure and so forth, and had a heart valve problem and was awaiting surgery in our nursing home unit when he expired. That significant infection difference over $300,000. So that's just one case of two patients that were matched for diagnosis on admission and comparing what happened to them. So we know that when we complete our analysis, it's going to be very interesting for us to look at all of that data.
Okay, great. Thank you. Our next question is from Cheryl Poyer, who asks, and I believe this would, Pat, be for you, is are all the tests for MRSA done by PCR? In other words, the admission, the transfer, and the discharge testing.
Okay. We decided early on in consultation with our Chief of Microbiology, Dr. Charles Steger, and our Chief of Diagnostic and Therapeutic, which covers the laboratory, and our supervisor, Leanne Chai, who are integral members of our team, that it didn't make sense to do PCR for everything, so we decided to do PCR for admission swabs. So anytime a person enters a unit, they have a PCR test done. Anytime they transfer and then are entering the next unit, they get a PCR test done. But when they go home, they get a selective auger, and we've used two different ones in our protocol. And now we have one that gives us a final result within 24 hours.
Great, thank you. Question for Dr. Awad. Did you ever, and I think you referred to this in your closing comments, but the question is from Kim Newman, who asked, did you ever implement CHG, which I imagine might be chlorhexidine bathing, or nasal decolonization for your cardiothoracic patient population?
That's a great question. Our standard of care at the time that the study was done was not to offer that routinely for all patients. All that we followed was that all patients were instructed to do the chlorhexidine-based bathing the night before and the morning of surgery. But we did not target anybody to decontaminate them specifically, and that's the purpose of the study that's currently going to be ongoing, is that we actually are going to target that. And for the first time, we actually will randomize the patients to decontamination therapy versus not and take a look at what the outcomes are with respect to compliance and surgical site infections. So it's very, very important to be able to do that, and the way we're going to be able to do that is having the rapid PCR technology available such that these patients, during their office visit, at the time they're signing their consent for the surgery, will be identified, educated, and then sent on their way with the therapy so that they'll start that before the surgery.
Great, thank you. And for Pat, we have a question from Gene Jones, who asked if you could please explain how you implemented your secret hand washing program.
Well, we haven't completely implemented that yet. What we asked for were volunteers who could come to me and say, yes, I'd like to be involved. Usually the nurse manager, most of these were nursing personnel, others were in different departments, but the only identity, their identity would only be known to me and to their immediate supervisor. So we didn't have a mass meeting and say who wants to be involved in being a secret shopper. And that's a little problematic as far as setting goals, like I need so many observations on such and such unit every month. And that's one thing we're trying to get set right now. How many observations do we need? Who should do them? Where would they be that they wouldn't be suspected of being the monitor for some sort of practice, that they would fit into that setting and no one would question why they're there. And so that's the challenge right now. We do, the unit staff on each unit trades around the opportunity to do observations and does not make it immediately evident that they're doing it, and then writes down the results and submits them to our office once a month. We think it would be better if we had completely unknown observers. So we're still working on it.
But I will add in that just the fact that the unit knows that there is this secret police actively watching, that in itself is enough of a deterrent. And I can personally attest to this in the surgical intensive care unit when we had fairly low observed from the police compliance with hand washing. By just announcing that there's somebody there, Big Brother's watching, all of a sudden our compliance increased. And so just by having that statement to your units as you implement it is even worthwhile doing.
And part of the culture change that occurs here, too, is to empower everyone to say something when they see that someone has not cleaned their hands. And that's vital. Whether it's a physician to nurse or nurse to physician or housekeeper, dietitian, whoever, we want everyone to feel comfortable knowing it's the right thing to do, and if they see the incorrect practice, they're empowered to say something about it and try to correct the behavior at the time. And we also reward those that we see doing correctly all the time.
That extends to patient families, too.
Yes.
Right. Okay, good. Also on a related note with regards to your hand washing, there's a Paul Lovin who asks, what is your reasoning for washing on the way out of the room? We currently foam in and foam out.
Oh, that's an excellent question. Thank you for that. We actually had that question from our Joint Commission surveyor, and here's our rationale. We decided to do sanitizing in, and we have demonstrated the effect of sanitizer against all the hospital pathogens by doing hand cultures with physicians, with other staff, so that they realize the effect is immediate to kill the organism going in. That kind of helped us with them taking ownership of this whole idea of sanitizing in. We made sure they were outside every room. Then we said, you have to wash coming out because we know from CDC hand hygiene guidelines that they always say you should remove gloves and wash your hands. The second point being that Clostridium difficile is not killed by alcohol hand gel, so we wanted to cover all hospital pathogens in the protocol, and we suggested then that once you were hands-on, had gloves on or not, that you would wash your hands coming out and help us control the transmission of Clostridium difficile.
Excellent. Next question is from Juliana Craig, and I believe actually, Dr. Awad, you may have even published a paper on this recently. The question is, what is the skin antiseptic of choice used for surgeries done?
That's a great question. We were very privileged to participate in the multi-center trial looking at chlorhexidine versus betadine for clean contaminated surgeries, and found that chlorhexidine-based products decreased surgical site infections by almost 40%. And so this was an absolute reduction, not a relative reduction. And this really has transformed our practice. I mean, we had been seeing that during the study, but after the study was completed, we now use chlorhexidine as our agent of choice for all skin preparation. And this data is not, it's only, if you look at it, it's really an extrapolation of the data that we learned in the ICU where we've eliminated betadine for any type of central line insertions. And this has been shown through multiple other studies. So clearly in 2010, chlorhexidine-based antisepsis for the skin is the way to go. In terms of trying to limit your chances of any type of infection, whether it be catheter-related bloodstream or surgical site. But at the time of the study, we were not doing chlorhexidine uniformly.
Okay. Kind of on the same line of questioning, how has the pre-op antibiotic prophylaxis been affected by this program, or has it?
Again, an excellent question. I will tell you that we were one of the first hospitals to basically adopt the SCP guidelines. First, they started a SIP, which is actually giving the antibiotic within 60 minutes of skin incision, and then followed by the appropriate antibiotic, and then followed by discontinuation within 24 hours, and then it's evolved into the SCP guidelines, and we have been compliant with that ever since 2004, when these recommendations were spread at our hospital and then VA-wide, and now are mandated throughout the country. And so we actually get performance measures based on this and real-time feedback every quarter with how we're doing, and our compliance in these are way above 97 and 98%. So in terms of giving the antibiotic in a timely fashion, using the appropriate antibiotic, and then discontinuing the antibiotic within 24 hours for clean cases and clean contaminated cases.
Okay, we actually have a couple of questions here. I think this will probably be maybe for Pat. Along the same lines, one question is, do you anticipate decolonizing MRSA positive patients, or have you tried decolonization of patients to remove them from isolation?
Okay. Number one, we would like to consider decolonization in the surgical setting, and that study is hopefully will start shortly, targeting those that are highest risk for infection with an implant. Do we do it now? I can tell you I follow mupirocin use. We have it used sporadically. We have it sometimes used for the nares decolonization and other times applied to a wound for treatment. So we don't have a routine protocol for decolonization. So we know that during the period of the study, some decolonization may have occurred randomly throughout our patient population, but there was no protocol for that. And what was the second part of the question?
Just would you decolonize individuals to take them out of isolation?
Well, we have such a high prevalence here in admission that we decided that we needed to work on the bundle as it was and not add anything to it at this point until we could see that our infection prevalence certainly on admission would go down. We haven't seen that. In the last year, the prevalence actually went up a couple points to 20% on admission. So, and I think we've seen that reported in the literature, perhaps in the media, that there is an increase in MRSA infection in the community in certain settings, and Houston seems to be in one of those cities. So, yeah, it'd be great to be able to institute discontinuation protocol, but we didn't feel it was cost-effective at first to do that, and you'll say it probably might be cost-effective if you look at the cost of isolation, but for us, our length of stay has decreased for a lot of our patients, especially in the ICU, so they're not staying as long, and so we felt comfortable maintaining isolation. It's really confusing to staff to keep testing once they're positive, because what you see, and I'm sure those of you that do this will see that they're positive on admission. They'll test them on transfer, they'll be negative. They'll test them on the next transfer, they'll be positive. So, you know, we do see variations. It's either the technique that's being used or the fact that there are low enough numbers that PCR can detect it, but they might have transient colonization. But we're going by the CDC definition that says any history in the last year, the patient is assumed to be colonized, even though we only test one site.
If I may add, in the same New England Journal of Medicine article that looked at the chlorhexidine versus betadine for surgical site infections, there was another article that looked at the effect of decontamination in patients who were admitted and found to be MRSA positive on screening, and they actually showed that it could translate into a potential decrease in hospital-acquired infections, but they only reported on surgical site infections. And this was after the fact, after the surgery, which has led us to do study and trying to implement this type of strategy before. But in terms of the way to do this is to implement the bundle first and look at your infection rates and transmissions and actual hospital-acquired infections. If they're not going down with good compliance with the bundle, then the next step would be to try to potentially implement the strategy of a decontamination therapy for those patients who are admitted positive with MRSA in their nares, and then go from there. And I think that in terms of the bundle, this potentially could be added in places where they show good compliance, show the fact that they're able to, and still have high transmission rates, but in fact can now need to implement a therapy to try to decrease the rates.
And I must say, if you review the literature, there There are some studies that show great efficacy in decolonization and others that don't, and you see patients periodically, then once they've been treated, they're colonized again. And whether that's a new exposure or their existing endogenous pathogen, I don't think anybody really knows. But additionally, antibiotic stewardship should probably be part of anyone's approach to decreasing MRSA or any other kind of healthcare-acquired infection.
Yeah, that's a great point, actually.
Well, we have a number of questions here about your surveillance program, and one of them is, do you perform weekly PCR surveillance? And then another person asks actually what the turnaround time is for your MRSA test.
Okay. Well, we base it on patient movement, and so whenever the patient moves, they get swabbed. Some facilities, when they implement in an ICU, for instance, they would start out doing weekly retesting. Now, we do retesting in our spinal cord injury unit. We do that every 2 months, and that's because physicians change every 2 months, and the automatic orders would be there, and that's what we've done. In our nursing home unit, because of the high prevalence in that population, we have decided to get a better handle on what's going on as far as transmission. Anyone who's negative would be rescreened each month, and that's yielded us some very important information so that we can target how the transmissions are occurring. So that's the only kind of rescreening that we do. Otherwise, it's on patient movement.
And there's a question on your turnaround time for your...
Oh, the turnaround time, not as good as we'd like. I told you we only do this for 12 hours during the day and have it staffed in our microbiology laboratory. Specimens are received all hours of the day. The staff is there from 8 in the morning till 9 at night. And so anything, unfortunately, that's received later on in the evening may not be set up until the next morning. So I always tell people you should have a result by noon the next day if you submit it in the evening. So that's something we're working on.
Okay.
It's so much faster than doing it the traditional culture way.
Certainly.
Okay. On a related question, from an Angela Calloway asks if you are going to be using the Cepheid direct wound MRSA, MSSA PCR for screening wounds that admit or acquired healthcare-associated SSIs.
Oh, very good question. We were just talking about that the other day with the laboratory. Part of our MRSA initiative, it's evolving now. We have new software to be able to track our surveillance data and to be able to track patient movements. The one thing we talked about is in our spinal cord injury patient population, it's actually recommended in our VA national guidelines that all open wounds be screened on admission. That raises the issue of does one swab the surface or does one do a proper wound culture. In this case, we're not looking for necessarily a proper wound culture, but as you're probably aware, the media that are generally available now as selective media would not enable you to screen a wound. However, I'm assuming that the Cepheid wound reagent would allow us to screen a wound. And so we're going to be looking at that for nursing home patients as well as our spinal cord patients. We have actually done some preliminary studies here in our infectious disease department to validate the effectiveness of the reagent, and we know that it's very sensitive and specific, but we have not made the decision yet to adopt it.
Okay. Another question from Anoy Mateo asks, how do your nursing homes or transitional care units handle newly identified MRSA positive patients?
Well, I don't know if any of you are aware of the VA guidelines. There is a new protocol that was set up just for the long-term care patients where we had standard precautions. We had what are called enhanced standard precautions. And then we had contact isolation. And these were recommendations made at the national level, and each facility was given the flexibility to decide in their own setting whether they wanted to do enhanced standard precautions and do a risk assessment with each patient when they were admitted to see if that patient was high risk or low risk of transmitting infection, period. A lot of it based on his cognitive abilities, the ability to follow directions, and also whether there were any open wounds, whether there were any active infections, how many invasive devices were involved, and that assessment would have to be made on admission, low risk, high risk. We tried it on one of our nursing units. It did not seem to work well. So now all of our patients are placed in contact precautions, even in the nursing home setting, with a history of MRSA going back 1 year, or a recent culture positive or screen positive for MRSA, either on admission or perhaps when they were in the hospital prior to admission to long-term care. I hope that makes sense.
We have just a few more minutes left for questions. We got a couple more here, very much along the same lines with regards to the subject of healthcare workers. It says, have you looked at the possibilities of colonized staff members that you're not aware of contributing to rates? And then another person asks, some studies show that 30 to 40% of healthcare workers are colonized. Do you test healthcare workers in your high-risk areas?
Well, it is VA policy that we will not test healthcare workers unless we have an outbreak on a specific nursing unit or in a specific practice area. It's assumed to be a private health matter. Now, if an employee comes in and talks about the fact that they've been out because they've had an MRSA infection, we usually get called at that point. What do we do? And so we can talk to the employee. It's a fairly common problem in the community, so it's not unlikely that this would be occurring. But unless we have an outbreak, and we have had outbreaks through the years where we've had to test employees, but I must say also that we should be using standard precautions for every patient contact. That means you're going to be cleaning your hands. You should keep your hands out of your nose. Make sure that you clean all your equipment. Make sure that cell phone in your pocket gets cleaned as well, that your stethoscope gets cleaned, that all your medical equipment's cleaned when it's used between patients. And with attention to those items of the bundle, I think we can decrease the chances that an employee would be the source of an MRSA infection for a patient.
Okay. One more question here from Michelle Poyer. I guess this would probably be for Dr. Awad. Did you give vancomycin pre-op prophylactic antibiotics to known positive MRSA patients?
That's a great question. If the patient has had a known history of MRSA infections within the past year, those patients get vancomycin. But to be honest with you, our cardiothoracic surgeons and orthopedic surgeons, basically, no matter what the status is, because of the, again, perceived high prevalence of MRSA in our community here and in our carriers, prescribe vancomycin nilly-willy to everybody. And that's why we are hoping with the targeted approach study that we're going to be embarking on very shortly, is that we will be able to identify the patients that would benefit the most from using vancomycin, and then looking at other patients who may not be MRSA positive carriers, but maybe MSSA positive carriers that would benefit from a cephalosporin or penicillin based, where that's a lot more efficacious against that skin colonizer. So we, during the study in cardiothoracic and orthopedics, most of the patients got vancomycin up front.
Good. And I think
what was interesting is that despite that, there were still surgical site infections.
Okay, and for our, I think probably time for our last question, which I think it may be interesting to get both your perspectives on it, is Cindy Kelly asks, do you specific scripting to encourage hand hygiene? She goes on to ask, how did the staff feel about approaching physicians that were non-compliant?
I'll answer first from personal experience where I actually failed in a rush early on, and I had the unit clerk come up to me and say, Dr. Awad, I am extremely disappointed in you. I just watched you go into 2 different patients' rooms, and you did not wash your hands on the way out. How could you? And that's kind of the empowerment that our culture has been transformed to. A unit clerk, you know, we basically now have tried to remove the boundaries via this collaborative effort by approaching the clerks, by approaching the facilities management crew, the nurse, the healthcare professionals that are working with us, such that we all keep an eye on each other. And it's with that that we encourage each other. So not in a bad way, not in a punitive way, but in a, hey, next time, please, you know, be sure that you do that for the sake of our patients, for the sake of our hospital.
Yeah, and I would echo that we want everyone to know that when you're providing care to a patient, you know the patient's watching you, you know the family's watching you. We all need to watch each other, and when we notice that there's a breach, instead of going on about our merry way because we're busy, we now know we're empowered to say something to the person with a smile on our face. We don't script it, but we do have weekly meetings still to this day with our MRSA prevention team. All the units are asked to send a representative. The champions change all the time. There's re-education going all the time. And we try to make sure that when we go around to each nursing unit, they have a chance to ask questions. How can I do this better? This is what I'm seeing. I'm not seeing a change, or I am seeing a change. And frankly, I'm amazed at the number of individuals who are medical support assistants and health technicians who have embraced this change in culture. And now, instead of just passing someone by, will make themselves one of the main champions for their unit, even in the ICU setting, and will let physicians or anyone else, certainly those that rotate through monthly and are new, to make sure that they get the proper orientation. And occasionally we might have to do hand cultures just to reinforce this is what you're carrying on your hands. And we have the full support of the chief of the medical care line and the chief of the operative care line to do these kinds of interventions to make it much more evident to people why we're talking about hand hygiene and why we're valuing the practice.
Excellent. Well, thank you both again for your presentation, and I'd also like to thank the people online for their participation, and to remind them that if they would like to receive an additional information and or a copy of today's presentation, to please fill out the survey immediately following this webinar. And also to let you know that a recorded session will be available for your few days for your review on the Cepheid website at www.cepheid.com/events. And you can also refer to the events page on the Cepheid website in a few weeks when we will be posting some of our upcoming webinar events. So this concludes today's program, and thank you again for your attendance and participation.